We start the recording. So welcome everybody to this webinar on introducing the topics of designing MAMS and platform trials. I guess the first and most obvious question is what is a MAMS trial? And I'm pretty sure I've seen the title used to cover quite a few different types of trial. And I think part of the problem is although the name seems very self-describing, multi-arm, multi-stage trials, unfortunately, that could actually cover a whole multitude of different things. A multi-arm, multi-stage trial, it could be a conventional dose-finding study, it could be a multi-arm phase 3, it could be an umbrella trial, it could be a platform trial. But if we look at the original paper and also the R package, it does look like there's a more tightly drawn use of the term that the originators of the term intended. And that is that it should be frequentists, confirmatory, type 1 error, family-wise error rate controlled, with a fixed number of arms, a multi-arm trial with a number of interims, and importantly, where each arm might independently be declared successful. So this is not a dose-finding trial. It's not a multi-arm trial. It is very much like an umbrella trial, but one where the thought was to control type 1 error and the family-wise error rate over the entire trial. And the first MAMS trial, arguably, was something like the Stampede trial, which started out as a fixed trial with overall type 1 error control of a fixed number of arms. It started running it's a prostate cancer trial. It started running in 2005, and in 2010 it kind of morphed into a platform trial. At the same time, one of the other sort of founding platform trials started, the iSpy2 trial, platform trial in breast cancer. But the first sort of paper on MAMS was in relation to this module in the Stata by Patrick Royston et al., where they were indeed providing this kind of overall type 1 error control in the context of kind of like a parallel group sequential trial with multiple arms. There is now an R package, a MAMS R package by Thomas Yaki, Pullman, and Dominic McGeer, which we'll have a look at in a moment. I gather East had a MAMS option as long ago as 2016, so probably, or certainly still has one, may have something fancier than it had in 2016. AdPlan in 2014, it had a multiple comparison module that allows the design of something like a MAMS trial, complete with family-wise error rate control, but it's not using the statistics that were developed by Patrick Royston et al. And we'll also have a look at that. And then finally, FACS 7.0 does include a platform trial simulator, which we can indeed use to simulate MAMS trials. And so we'll have a look at that too. So just to get a sense of what's what, I had a look at using the MAMS R package, and I thought, well, let's create a nice straightforward example. So I said, well, maybe we've got 5 treatments, all comparing against control, and I'll have 2 interims, so it's a 3-stage trial. course, one-sided alpha, 0.025, power of 90%. We'll have equal allocation to the treatment arms in each stage. So they have this parameter R, which is the proportion, or the proportion of the cumulative proportion of subjects in the 3 stages. So we're simply 1, 2, 3, so it's equal size in each stage. And I'm allocating twice as much to control. So I'm doing 2 to 1 to 1 to 1 to 1 allocation. So the allocation to control is specified separately with the R0 parameter, and I specify that as having the values 2, 4, and 6, so relative to the values of 1, 2, and 3 for the treatment arms. What I'm going to ask it to design is a trial where my treatment response my target treatment response for calculating the sample size is a 1-point treatment improvement compared to control on 0, and with a standard deviation of 2 in this expected standard deviation of 2 in this endpoint. So that gives us the parameters delta equals 1, that's my expected treatment effect, delta 0 equals 0, the response on control, and standard deviation is 2. It's important, what you have to do if you're using that method of specifying the treatment response is you have to set 2 other parameters to null, explicitly P and P0, because they've got a slightly unusual way of specifying the response rate, which is their preferred method, where you're talking about the probability of success for each individual patient. So you would be targeting, say, a rate of 0.75, meaning that 3/4 of the time a patient on the treatment would do better than a patient on control. And then you have to specify a lower limit on that, the P0. So specifying that at 0.5 would be saying that the lower limit, the null rate, is where our treatment is the same as control. So it's got a 50-50 chance of a patient being better than a control patient. And we're going to set the upper and lower boundaries to O'Brien-Fleming boundaries. So we set the upper shape U shape to OBF and lower shape to OBF. I'll come back to the boundary options in a moment. So this creates us a trial. It says it takes a couple of minutes to run. It says that this is our sample size. So what it's calculated for me is the sample size I need. So it says for each active arm, it's going to be 30 patients per stage, 30, 60, 90, with, of course, twice that on control. So that gives me a maximum sample size of 630. And then it gives me these as the upper and lower bounds in terms of test statistic. And then we can run simulations of this design using a second function in the package called MAMS.sim. We can ask it to run, say, 10,000 simulations. We need to supply a matrix with a number of subjects in each arm at each stage, which we can create simply using 2 of the values in the trial object that the MAMS thing returned, which I called m.obf. There's the n, which is the kind of like the basic sample size. So in this case, 30. And then there's the RMAT, which is a matrix of the which is the fraction of that sample size for each arm in each stage. We pass in the upper and lower bounds in the design, where I simply pass in the upper and lower bounds that are contained in my design object, so m.obf, .eu, and .l. I define the result again using the delta and the standard deviation, not the probability of better response. So I have to set that parameter null to null, the PV parameter, and then I input a series of treatment effect sizes, 1 for each treatment, and the standard deviation, which should have been 2, of course. And then also we can tell it which of the arms we wanted to test for to be significant. So here, of course, we want all the treatment arms tested. So that's specified. That's given the indices 1 through 5. So we can create 3 lots of simulation results, one under the null, so all the treatment effects are 0. One under what's called the LFC, the least favorable configuration, which is least favorable for the power, of course, where all but one of the arms are null, and then one of the arms has the target treatment effect. And then I created an alternate scenario where the arms have got a range of treatment effects varying from 0 up to the target treatment effect of 1, just to see what the characteristics of that were. And this is the results we get. So under the null, indeed, our probability of rejecting at least one hypothesis is 0.025. The probability of rejecting the overall hypothesis is 0.005, and our sample size is 6.29. Under the least, should be least LFC, should be least favorable configuration, we have a probability of rejecting a hypothesis of 0.9, and so we've met our power. We've got 0 chance of saying that everything's successful, and same power, of course, rejecting one of these treatment arms. And the sample size is now nice and reduced. It's 520. And in my alternate universe with a range of treatment effects, the result is pretty similar. It's a 0.92 and just marginally smaller sample size. Now, first thing that struck me as being very odd here is that the early stopping under the null is almost 0. So the maximum sample size, if you recall, was 630. And it's saying that the expected sample size under the null, or the expected average sample size under the null, is 629. So it's just one subject less. And what I think is going on here is the package has got this a really, frankly, rather odd interpretation of the O'Brien-Fleming bounds as applied to futility. And in fact, if we go back to see what it had delivered, if we look at here, what it's done is simply flip the boundaries for the first 2 stages by making them negative. But then, of course, at the final analysis, the boundary is the same. So those are extraordinarily conservative bounds, and no wonder there's no early stopping for futility. The type 1 error is well controlled. The power is 0.9 as required. The sample size under the alternative we've got the reverse thing going on. That's 520. And if we're not stopping early for the null, and we're only stopping early for success, and there's only one arm successful, it's a little difficult to see how that one arm stopping for success has reduced the expected sample size by 110. It's difficult to get to the bottom of what's happening here, and which is one of the problems with the package, which is that we just get these overall operating characteristics and no individual simulations. And also the operating characteristics we do get are incredibly high level. There's an awful lot of operating characteristics that we're missing here, such as results per arm. But because we're looking at the design, the normal 2-arm group sequential would have a maximum N of 180. Using O'Brien-Fleming, alpha and beta stopping bounds, it would have a expected sample size of 114, 15 under the null, and 140 under the alternate. And if we were going to run 5 of those in parallel, separate trials, we'd have a maximum required sample size of 900 instead of 630. The expected sample size, if they were all null, would be actually less than this design, 570, but that's because of these peculiar boundaries. and quite a considerably higher expected sample size if they were all effective, if all the arms were effective. We didn't actually simulate that in the MAMS, but presumably that would be even smaller than 520 as compared to 700 if they're separate. So the package has got some definite limitations. So it can calculate these boundaries for 3 stages. That took a couple of minutes. I haven't presented any results for it, but I did run it when I said 4 stages, and there it took approximately 2 hours to calculate the boundaries. And they do warn you in the documentation that 4 stages is pretty much the upper limit. To compute for 5 boundaries, I think would take days. East, I gather, well, I understand, has an approximation to the method that avoids this problem of the time taken. The boundary options are very limited. They offer O'Brien-Fleming, triangular, and Pocock, and also user-specified boundaries. As we've seen, the O'Brien-Fleming boundary is rather peculiar for the futility, and the way you set up the boundaries with the user specified, it's also a little, I found, awkward to work with. What you do is you supply a ratio for the test statistic at the different boundaries. So for the upper boundaries, you supply, for instance, their example they give is this little function that returns x to 1, where x will be given the number of stages, so it returns 3, 2, 1. So it would give you an upper bound test statistic of 6 for the first interim, 4 for the second, and 2 for the third. And this particular example is even more, is also wildly conservative. It would have been really nice instead to being able to specify the alpha and beta spending, which is for me a much more natural way to think about these. And crucially, you've got no individual simulation results and these extremely limited operating characteristics. No probability to reject the null by arm, and no breakdown of the probability of stopping at each interim by arm. So it's kind of really hard to get any detailed sense of how the design is going to perform. And my usual complaint, as is all too often in group sequential statistics packages, the software is misleading about the expected sample size because it doesn't ask the time to endpoint and the accrual rate. And in fact, it doesn't even warn you that there is an issue that you are likely to you will over accrue by your average accrual rate and the time to endpoint. So what if instead of the MAMS package, what if we use some piece of software like AdPlan? How does that compare? Now, one of the things that this MAMS package, the MAMS package is going to differ from AdPlan in 2 respects. One is it can calculate for us the sample size we require, and secondly, its analysis is slightly different. So what I'm going to do is first of all start by sample sizing just the simple 2-arm group sequential case, and then I'll use that as my starting point for the sample size of the multiple comparison example, and then we'll do a little bit of iteration at the end to get the power we want. So we can do this in actual real AdPlan. So say I want to do a test of means group sequential design. I specify the number of stages, the significance level, the power I want. I'm going to specify alpha and beta spending. And I'm going to use what they call the O'Brien-Fleming type alpha and beta spending boundaries. So they're not exact O'Brien-Fleming, but they follow his general scheme, which is kind of like a square law. For the group sequential, I'm just going to do equal allocation. And I'm just only interested in the one effect, the one where the treatment effect is 1. It's a 2 sample test and my variance is unknown. And I want to find out what the sample size is. So we run that. It's added. I've already run this one, so we've just got a duplicate set of results. So it just summarizes what I've asked it for, and then it tells me what the power is, what the expected sample size is under the null, under the alternate, what the halfway sample size is. If so, in this case, it would be an effect size of 0.5, and my maximum sample size would be 180. And then I get a little report at the bottom telling me a little bit more about the design. So I get told what the boundaries are in the test statistic, and you can see its OBF boundaries are quite different for futility. And then it gives me, in particular, it gives me a sample size. So 30 per stage. But interestingly, is the same as the MAMS package has given me for the 5-arm case with a 2-to-1 allocation. So now we're going to enter the multiple comparison design in our plan. Now we can't design in our plan's terms. A design is where you can do fixed closed form calculations of things like type 1 error and power. For other types of design, where it can't do that, we need to do a simulation. So we're going to create a simulation test of means of a multi-arm. And we have 3 stages, and we want 5 test arms, significant level of 0.025. I'm going to use the defaults. These are probably the best to use for this. I'm going to use a flexible combination test. So what it's going to do is it's going to combine rather than one overall p-value, it combines the p-value at the different stages using the inverse normal method for allowing for adjusting for the multiplicity at each analysis, the multiplicity due to the number of arms. We'll use a Dunitz test, and of course we'll have unknown variance, and we'll also do 10,000 simulations. For the sequential design, well, once again, we're going to do alpha and beta spending, and again, we'll have the O'Brien-Fleming type boundaries. Just remember to change set the power is 90%. And then on the tab called parameters, which from Facts World, this is our scenario, this is our virtual subject response. I want to be able to specify the response separately for each arm. So first thing we do perhaps will be the LCF, the LFC, the lowest favorable combination, and we'll do a drift from, well, we're not going to do any drifts at all, and we'll do a standard deviation of 2. And one of the things that our plan is expecting you to do, or certainly is allowing you to do, is that one of these interims is to make a selection where you narrow down your choices. Now here we don't want to do that. We want to allow every arm to potentially run to the end, and it's only going to stop early if it crosses the group sequential boundary. So I use select the R best arms, and I give it the maximum. So just select all the arms. So effectively it's a null operation. So the rest of this doesn't really matter. And then lastly, we have to tell it the sample size. And well, I'm going to start out by putting in the 30, 30, 30 that we got from the group sequential design. And then I have to change the allocation ratio to 0.5. This is the ratio of the allocation to treatment compared to control. So this is doubling the allocation to the control arm. And then we're not going to do any sample size reassessment. And we'll kick off some simulations. And now we can look at our results. So let's just scoot back over here. So in the first things we get shown are the parameters that have been entered. And then we start to get the results. So here we see we've got the probability of rejecting at least one arm is 0.73. So we've got nowhere near our 90% power. Our Teichmann error, the analysis here is more conservative and less powerful. If we change that to a 0, so we can simulate the null case, we can just see that. So there you can see that the probability of rejecting at least one arm is 0.01, so well below the required 0.025. So the scheme is conservative. You can see that we've got a slight chance of rejecting the null arms and this 0.736 chance of rejecting the one arm that's good in that first scenario. And if we scoot over, we can get to have a look at some of the expected sample sizes. So the expected sample size under the successful one is 514, and in the null case, it's 400. So compared to the MAMS package, we have got a much smaller expected sample size under the null. So we've got much more conventional, normal, and usable O'Brien-Fleming bounds for futility. There's one thing that you can note here, and that is the probability of rejecting these, because in the first scenario, if you recall, arms 1, 2, 3, and 4 were all nulls. And if you can see, that probability is slightly greater than the probability when they're all null. And in fact, if we go back, and if we now simulate kind of the reverse of the least favorable, which might almost the most favorable, except they're not all positive, we'll leave one null. And now if we simulate that, you can see the simulations when there's an effect is smaller. The futility simulations are presumably stopping a bit quicker and requiring a little less computation, but not running to the very end so often. And there you can see we have in the individual successful arms, we now actually have 90% power. But also you can see that for the one null arm, we now have pretty much 0.025 Teichmann error. So I like so this is an effect of the closed, I believe this is an effect of the closed testing procedure. All these intersection hypotheses, the more of the other hypotheses are getting rejected, the greater the chance that the null case will also get rejected. We can think of this perhaps as a kind of a frequentist borrowing. It's almost behaving a little bit like a Bayesian hierarchical model. So we have a problem though with this design, that the under the least favorable configuration, our power was not as requested. It was not 90%, it was 0.7, and we can so we can go back to running that simulation and trying some different sample sizes. And indeed, what I did was I tried 40 and then 45, and then that gave us a little bit more power than we needed, and stepped back, and we find a sample size of about 43 per active arm per stage gives us the sample that gives us the power we were looking for.
Tom, we've got some questions.
Right. Yes. Well, now's a good time to look at questions.
Okay, I'm trying to figure out where to start. I'll start at the top. Ronan said, I assume the primary factor being highlighted as to why these differ is the very different boundaries between AdPlan and the MAMS R package. Usage of p-value combination versus the GST done-it test has some effect, but is presumably swamped by the above.
So I think there are two things. There are two differences. One is very definitely the futility boundary, but clearly there is also a difference in the analysis that the MAMS package is doing compared to the AdPlan. The AdPlan's sort of close testing procedure and combination p-value test, it isn't as powerful as the analysis that the MAMS package is doing. But I'm not completely familiar with the details of what the MAMS package is doing. So I'm afraid I can't give you a definitive description of that difference.
Okay. Would the MAMS test of means simulation module in AdPlan also apply for G=5 doses as opposed to independent treatment arms? Or is the module inappropriate in this situation if it doesn't account for dose response?
Yes, I think that is, yes, your last sentence is, I think, correct. Because there's no allowance of dose response, this would be a very inefficient way of testing multiple doses. If you're testing doses of a treatment, you've almost certainly got an expectation of a dose response, and you're much better off fitting something like a sigmoid or some sort of smoothing curve if you can't assume monotonicity.
And then finally, why is the probability of rejecting arm 5 so high if its effect is 1?
Yes, this is the peculiarity of stat speak. By rejecting, what they mean is they're rejecting the null hypothesis on that arm. So this is, in other words, it's been successful. So I think what you're talking about is, reject arm 5 here in the first scenario where that has a response of 1. And what they mean is they're not rejecting the arm, they're rejecting the null hypothesis on that arm. They're declaring it successful. And now the simulations for sample size 43 are complete, and you can see we've now got our power of 0.9. But of course, we've now got a much bigger sample size because we'll have we'll have 43 up to 43 subjects per active arm per stage, so 129 per active arm overall, which gives us a total of 645, and then the control will be twice what an active arm will have, so that'd be a further 258. So your expected maximum N would be just over 803. Excuse me. So there's a little summary of the results we've just seen. The top one, the top little table, is the probability of rejecting at least one arm under the 3 different scenarios when the sample size was 30. Then there's a little the output from my little sample size exploration, and then sampling at that new sample size and looking at some further results. We have the probability of rejecting each one under the the least favorable configuration is 90%. That's our 90% power. We have 95% power in my little alternative scenario where there's some small effect size on the other arms. In the scenario where all arms but one are effective and the other arm is null, there's our 0.025 type 1 error being control. There you can see apart from arm 1, the probability of rejecting, that's to say, deeming successful, the arms 2 through 5 in the different scenarios. So you can see the probability of rejecting the fifth arm, which apart from the null case always has a treatment effect of 1, goes up as the number of successes on the other arms goes up too. So again, we've got this kind of slight frequentist borrowing effect. And then in the third line, where I've got a response of effect of 0.2, 0.4 and 0.6, you can see the respective power to find that successful, whether that would be the result you wanted or not. And then we can also see the probability of stopping at a different stage. And this would mean that all arms had stopped either for futility or success. So you can see there's a high probability of stopping by stage 2 in the null, and stage 2 also where there's one arm successful, because of course the arms are either successful or null, whereas in the third example, where there are a number of arms with a modest treatment effect, some of those, although the very good arm and the null arm might have stopped, those other ones will have carried on through to stage 3. And then we can see the expected sample sizes under this revised design. So oddly enough, under the null, it's actually better than the MAMS package, but on the others, the sample size is larger, and it's even larger than the max N that the MAMS package was coming up with.
Okay, can I jump in?
Mm-hmm.
Question. It applies to both MAMS and platform trials, I think. So when considering multiple arms, which power do you prefer to use to measure the operating characteristics? For example, conjunctive power, where you look at the probability of at least one success, or disjunctive power, where you look at each arm separately and analyze the probability of rejecting in MAMS or of declaring success in platform trials.
I guess that's a very interesting question, and it's going to depend, I think, on your circumstances. So if you think of a stampede trial where you're looking for treatments for prostate cancer, assuming this is a big assumption actually, but assuming any successful treatments are actually going to be roughly equal, then I kind of don't mind about individual treatments. I'm only concerned on my overall power to find a good treatment. But if we're designing a platform trial, which is going to be a cross-company, the Stampede trial, I think, was using repurposed treatments. So these weren't new treatments. These were treatments that are already approved for other uses. But if we were going to design a trial where we were like the iSpy 2 trial, where we're inviting sponsors to bring their treatment in, and each one will care very strongly about the probability of their treatment being successful, then of course it's very much the individual treatments being apparently individual treatments that we care about, rather than just the overall ability to find one.
Yeah, I think Kurt likes to use the example of antibiotics. A platform trial in antibiotics definitely has the goal of finding all such drugs that are good because of resistances of patients, and it's not just which one's the best, how fast can we find it. It's We want to know about each one individually. Does it work? And so that's sort of the conjunctive power. In something like ALS, it may be very different. You probably nothing really works. We want to get, cycle through as many things as possible, and the probability of finding one good drug, the conjunctive power, is probably more important in a setting like
that. So I want to turn to the fact now. And what I'm going to first do is to see if we can understand what the MAMS design is doing a little bit better. In the MAMS packages output the boundaries as test statistics, so we need to convert them to p-values. So we can use the little pt function in R to do that, and we can plug in the different test statistics and get the corresponding p-values for the success boundary. So we're going to use FACS Core for this simulation rather than FACS Platform Trial at this point. We'll get to FACS Platform Trial by the end. FACS Core has the advantage that it's got a couple of things I like, which we'll see towards the end. Some graphs that are going to help us come up with the success criteria we want to use in FACS. So entering it in FACS, so somewhere, let's put our plan away. Here's our 5 arms MAMS example. So on the study info, we want interims and early stopping, so we have to enable adaptive features. We recruit subjects continuously. We know our maximum N is 630. We're going to simulate a higher response being an improvement for patients. And in order to remain sort of comparable with MAMS and what our plan are doing, we're going to pretend we've got an almost instantaneous endpoint, so we avoid the question of overrun. Then we need to add in the treatment arms. So I keep adding arms until I get 5 plus control. And the virtual subject response scenarios, these are nice and simple. I make sure I set the standard deviation at 2. In the null, all arms have a response of 0. In the least favorable, one arm has a response of 1, the rest have 0. Standard deviation of 2 again. And in my little alternate, again, standard deviation of 2, and then they have that middling range of responses. FACS always asks, wants to simulate things happening over time, so we need to tell it what the accrual rate is. Here I've just created a very simple assumption that the accrual rate is on average 5 a week. So our 630 subjects are going to take about 2.5 years to accrue. And we're going to ignore the problem of dropouts. And the quantities of interest, well, to start with, we really only want the p-value, and we're going to use an unadjusted one, and then we'll make any adjustments we need in the alpha level we test against. And then we get to set up the boundaries. So we copy them over from what we calculated the p-values boundaries would be based on the test statistic boundaries from the MAMS package. So you can see they're vanishingly, they're enormous for stopping for futility, and correspondingly minute for stopping for efficacy at the first interim. Then a little bit more plausible, and then we finally get to 0.0079. So you can see there's again, it isn't quite enough in Bonferroni terms to adjust for the 5 arms. So the MAMS is certainly doing something, but at the same time, it is still using a quite reduced p-value level here. Oh, and did I show the interim? No, sorry. Why did I jump straight to success futility? Presumably that's where I beg your pardon. Let's go through these in order. So the design, this is for the Bayesian analysis, so we can ignore this for now. I will use the Bayesian analysis later on, and I'll keep it the same. I've got an uninformative prior, but I'm using an independent dose model, so just pairwise. I've just got a simple normal prior with a mean of 0 and a standard deviation of 10, which is very uninformative for this endpoint. And then a very, very weakly informative prior for the estimate of the variance, the sigma, where I've centered it at 2, but given it just a weight of 1, equivalent to a weight of 1 observation. We're not using the frequentist analysis. That's just this refers to a separate parallel analysis, which is out separately and not part of the main design, and is separate from simulating p-values of quantities of interest. I'm using a fixed allocation of 2 to 1 to 1, and I specify my 2 interims using the opportunity to complete at a specific visit, and we want 1/3 and 1/2 of the way through the trial, where the maximum is 630. So the first interim is at 210 and the second at 420. The 6 criteria we've already looked at, and then we get to run some simulations. And the most obvious thing is that as I said, these final criteria are not, they're reduced from 0.025 quite considerably, but they're not a full Bonferroni reduction, and we see correspondingly. Some excess success, excess type 1 error in the null case. We've got 0.0092 early successes and 0.0289 late successes. So yeah, that's almost it's almost 0.04 type 1 error. Obviously, yeah, correspondingly, we've got very good power. We've got 0.9, 0.93, adding those two together for the least favorable configuration, and 0.94, 0.95 for my little alternate. So we've got some room, as it were, to trade off some of this excess power as we reduce the type 1 error. One of the ways of looking at the type 1 error is to look at this thing we call the explore final success criteria, which shows for different p-value thresholds what proportion of the simulations would have been successful. I can shrink I can reset the x-axis to zoom in on that lower left-hand corner, but also I can simply ask it if I wanted 0.025 successes, what should the threshold be? And it tells me it should be 0.0046. So my next question is well, if I do that, what's my power and type 1 error? And also, what should my early stopping thresholds be, particularly for futility, which we're a bit disenchanted with in the from the MAMS package. So again, here is one I did earlier. What I've done is I've disabled any early stopping at the interims. I've used, in this case, I've under different runs, different random number seeds. I've got slightly different values for this. What I need to adjust the alpha level to for the final to control things at 0.025. And then we simulate it 1,000 times and output 1,000 what we call weeks files. So I've got a full record of all the interims in all my 1,000 simulations. So I've got no early successes because I disabled all the early stopping criteria. And you can see my probability of late success is now well below 0.025, 0.018, sort of giving me a little bit of headroom to introduce some type 1 error with the early stopping for success. And what I'm going to do, what I've also done is made sure I've got the probability of success is greater than control. What I had considered was you doing a Goldilocks design using the predictive probabilities of success, which is what I would have liked to do. Unfortunately, in our platform car simulator, we don't have that available currently. So I had to change tack and go back to just using sort of approximating the predictive probability of success with just testing the posterior probability of being better than control. The other reason we can't, did I say the reason we can't use core completely for MAMS is as soon as it finds one arm successful, it stops the trial. So it doesn't allow the other arms to carry on and be assessed at the end, which is why at some point we're going to have to transition to the platform trial simulator. But what I've done this simulation for with no early stopping and a full output of all the weeks files is in order to, oh, wrong graph. I want the across scenario graphs, and I'm going to use the interim versus final scatter plot graph. I've got to say, it takes a little bit of a while to load because it's reading in the 1,000 weeks files from each of the different scenarios, and it's looking at how each one of those has turned out. And it's going to provide an example plot to start with, which we then going to have to change and replot. So I'm only going to show this once, and then I've got the actual graph captured in the slides. Now, at one point, whenever you change one of these things, it would redraw, and as you've just seen, that takes quite a while. So now what we've done is suppress the automatic redrawing, and we can change whatever we like, and then finally we get to we click the redraw button when we've said, yeah, we've made all the changes we want. So the interim QOI, I want the Bayesian posterior probability that the treatment is better than control. And the final QOI is going to be the p-value. And my final thresholds will be 0.0044, as it were, as I'd actually set them. And then I'm expecting this to be have to be quite a high value, perhaps 0.99, whereas futility, that might be, 0.2 might be, or maybe even more lenient, maybe even higher. And we'll look at the first interim, and we're going to redraw. And what we'll see on this is first there's a scatter plot showing each individual simulation, so the 3,000 simulations, and their points are colored by their potential early outcome and their late outcome. So let's just redraw it. So you can see we've got an awful lot of red dots, And these are trials where the outcome was late futility. They all ran to the end and then they were futile. We have some light pink dots here, and these are ones that were an early futility. What's actually quite difficult to see, but if there's some dots here which are pink rather than red, and they correspond to this success that actually became a futility. So these were, with the current interim stopping rules, these would have stopped for success, but if I'd let them run on to the end, they would have been futile. So these are potential type 1 errors. And you can see there's a little bit of a bar there saying these are type 1 errors. Then these stacked histograms show me the ratio of the different outcomes: early futility, early success, late success, success to futility, flip-flop, and late futility for each of the 3 scenarios. So you can see the null is mainly futile with very little early futility, that tiny little pink band at the top, then some type 1 error, success to futility, and then some other type 1 error, but that's type 1 error at the very end, the little green band. So we can see for the futility, we could quite plausibly move the futility stopping threshold to 0.4, and we get a bunch more things that were futile at the end would now be early, and we'd catch just one trial that was successful at the end, and that would become futile. So that would be like a type 2 error. We could almost consider moving it up to 0.06 and catch a lot more, and just a couple more type 2 errors. What's going on in success is rather hard to see because this axis is the p-value. All the action is kind of down here in the little values. And what we do is set the axis and redraw and zoom in on this square, or maybe even closer. So rather than do that and have all the weighting, we'll take a look at that in the slide. So there's the screen we've just seen, thinking that we could maybe make the stopping for futility at the first threshold 0.6. And then this is the same graph, but now showing the second interim and suggesting that we could make the stopping for futility threshold at the second interim 0.8. If the probability that the treatment on the best arm if the probability of the best arm is on, probability that the arm is better than control, if that's less than 0.8, we could stop for futility. And then the success one here, we've zoomed right in. So the y-axis is now showing just from 0.99 up to 1. Sorry, the x-axis is showing from 0.99 up to 1. And the y-axis is just showing p-values below 0.1. And you can see actually there's potential type 1 error right up to a very high early success threshold, greater than 0.998. Because we're talking about 1,000 simulations of each scenario, and particularly just 1,000 of the null, and these are most likely to have come from the null. And so even right out here, we've got 1, 2, 3, 4, 5, 6, 7 failures. So we've got nearly 0.1% type 1 error, even if at the first interim, if we set a interim success threshold up here, which when added to your, which is actually quite a lot in terms of type 1 error, it's 0.01. So where we're going to have to be super conservative about our early stopping for success threshold. And at the second interim, there's a little bit less. Maybe we can back off just a little bit more. Maybe we can use a 0.999 threshold. So we're now going to go into the FACS platform trial simulator. And enter that. So what's my time? Yeah, I've got time to do this. Good. So I'll just show you how that looks entering this into FACS. So it's a platform trial design with a continuous endpoints. Again, we want some adaptive features because we want the interims for stopping. We'll keep with the short endpoint. I'm not worried about the maximum enrollment time. My maximum enrollment is 630 subjects. Actually, I want a little bit more than that in order to make sure all my treatments can complete. I'll just give it an extra 6 subjects. My max participants on each subject is 90. And I'm going to allow up to 5 concurrent treatments. And again, higher response is improvement. In the trial arms, I'm going to have a control and then 5 treatment arms. And because it's a platform trial simulator, one of the things we get to specify, one of the things we have to specify about the treatments is when do they appear? When do they turn up in the trial? Now here, I'm just doing effectively an umbrella trial where everything starts at once. So I'm just going to say everything starts at week 0. And because I'm allowing a maximum of 5 concurrent treatments, they will all simply go straight in. On the virtual subject response, one of the things we can do is specify thresholds for what should be classed as a good response or a good treatment and what should be treated as counted as an unacceptable one. I'm gonna put in somewhat arbitrarily boundaries of 0.5 and 0.3. So if I've simulated an arm with a treatment response of 0.6 or better, or greater than 0.5, then I'm interested in that being counted as a good response, and I'm going to want to know how often that was actually successful. Similarly, if it's got a treatment response of 0.3 or less, I want it to be I'm talking about that being a bad response or a bad treatment, and I want to be assured that I've got a high probability it's futile. And then we're going to add in to start with our 3 same scenarios. Least favorable and my little alternate. So the null standard deviation is 2 and the response on all of them is 0. On the least favorable, again, the standard deviation is 2 and treatment 5 will have enough treatment effect of 1. And in the alt, again, the standard deviation is 2 and then control has a response of 0. The mean effect on treatment 1 is 0. Then I had 0.2, 0.4, 0.6 and 1. Instead of specifying a fixed single value to simulate from in every simulation of a scenario, we can, when we'll look at this later, we can create a distribution which gets sampled from. So that allows us to sort of do things like assurance, estimating the probability of a success across our prior expected and effect size. Again, I'm going to have no dropouts. And again, the accrual, I'll just keep it at 5 per week. I'm not interested in the probability being maximum. I'm not interested in a future trial. I need to keep that for my early stopping criteria and my p-value for the final analysis. And as this is platform trial, there's no adjustment because obviously the number of arms varies and exactly how many you're adjusting for is kind of questionable. I'll keep the same non-informative prior for control and treatment and the same very weakly informative prior for the estimate of sigma. So I want 2 on control to treatment, regardless of how many treatment arms there is. So in each possible circumstance, I want 1 to each treatment and 2 to control. I have to specify the trial updates. So what I want is my first update at 210 participants complete, and then every subsequent update will only be 1 at every 210 participants. Now we also need to specify milestones for the treatments. In the umbrella case, this is a little bit overkill, but if you think more of a platform trial where treatments may be coming in later, the interim for the treatment is going to be governed by how much information there is on that treatment, not where we are in the trial. This just governs when they happen. So I want, so my first one is when there's 30 on an arm, and the second one when there's 60. But I might get a little bit unlucky in the allocation. There might be 210, but this might only have, say, 29 subjects on it. So I don't want it to miss being treated, being analyzed. So I'm going to just lower the number of subjects I require on the milestones so that the interim for that treatment is guaranteed to take place at the first update and then the second milestone at the second update. So now we get to specify the early stopping criteria. And we said we'd use the posterior probability for stopping. And if that's less than, I said 0.6, that'll turn out to be a little bit too aggressive, but never mind. And then for success, we said greater than 0.995, 995. Yep. Which actually will turn out not to be quite conservative enough. And then at the second look, we can weaken these a little bit. And then my final evaluation is going to use the p-value. And I was going to use 0.004. And then we can run some simulations. We'll just run the first 100. So we can see how many good treatments are analyzed on average. So none in the null case, 1 in the least favorable case, and 2 in the alternate. Obviously, these become more interesting when we're sampling from a range rather than fixed truths. So we kind of knew that. So we've got the mean number of successes. So we're 0.01. So that looks promising for the null case. 0.85. We could have really wanted that a little higher for the least favorable case, and 1.5 in the alternate case. And then you can see the number of successes broken down by the treatment type or the treatment class. So if they were good, we have actually the actual power is 0.84 rather than 0.85. And there's one of the successes was a type 1 error. There's just the 1 out of the 100 successes in the unacceptable treatments in the null. And then we can see things like the proportion of successes and futilities given a good treatment, and the proportion of successes given an unacceptable treatment. So you can see at the individual treatment level, our type 1 error is 0.002. This is only 100 simulations, so that's not very accurate. But so we'll click that and just look at the one I prepared earlier, where we've got 10,000 simulations. Let's just check what we had as. Yes, so this one has got the same criteria in as we plugged in. You can see the mean number of successes under the in the null cases is actually a little bit too high. It's 0.0283. Our power is okay in the least favorable, 0.9, but we're going to need to do some tuning to get that down. And what I started by doing was looking to see, because one of the things we're not very good at reporting here is whether their successes were early successes or late successes, because that in general really is only really meaningful per treatment. And one of the things we haven't got to yet is per treatment output files. But at the moment we can sort of take a look. Oh no, I'm going to do this in a spreadsheet. So here we've got some columns, which is the outcome per treatment. And we use the same outcome codes as we use in the rest of FACS, which is they're kind of intended to be in decreasing order of, the first one is the most favorable outcome, which is early success, then late success, then late futility, then early futility, then inconclusive. And then there's a couple of codes for flip-flop where you stop early for one reason, but it turns out to be the other. And then the last one is inconclusive. So here we're really interested in outcomes 1, 2, 3, and 4. So three is late futility, 4 is early futility. And what we're interested in is the few 1s and 2s that are out there, which are the early and late success. So we can see we had 21 1s for that treatment arm. And in all, we've got 116 early successes. And if I change that to looking for 2s, we've got 167 late successes. Adding those together gets to sort of 286, I think it was, which is the corresponds to our divide that by 10,000, gives us the observed time and error. But it gives us, doing this gives us an idea of whether our type 1 error is coming too much from the early successes or the late successes. So what I did was incrementally change the incrementally changed the criteria until I got some degree of type 1 error control. So is this the one with the type 1 error? Oh no, it's not. Hoping it's this one then. Yep, here we go. So I've got the type 1 error down to below 0.025. My power is in the least favorable configuration is 0.9, although if I look at how often I'm having success with actually is a good arm, strictly speaking, the power is 0.88, because we've got a couple of percent type 1 error when it's one of the null arms being successful. But I'm not sure that the MAMS module made that distinction. So what we've had to do on the success criteria is I've lowered the futility stopping at the first interim from 0.6 to 0.4, and I've raised the success threshold for early stopping at the first interim from 0.995 to 0.999. And then futility at the second interim is the same, 0.8, and the success is 0.995. And then I progressively reduced the alpha level at the final test from 0.44, but in steps of 0.002, and then finally got to 0.0038, and to reach the required degree of type 1 error control. And we can see our sample size is about 450 in the null, 470 in the least favorable, and 520 in the in my little alternate. So yeah, basically we've managed to replicate the MAMS package operating characteristics, but with much better sample size in the with better sample size in the null and the least favorable, and the same sample size in the alternate. And of course, we've effectively got the same overall sample size, 630. I've only put the extra 6 in just to avoid the situation where the trial stops and one of the arms hasn't quite got 90 subjects, and therefore it doesn't get a final interim. Okay. So the next thing we wanted to do, or the last thing, is look at turning this into an actual platform trial. So like Stampede went from its initial set of 5 or 6 arms or whatever it was, it then started allowing additional arms in. What if we plan from that from the outset, or we want to plan from that from the outset? So I'm going to go up to having 10 arms. So I've pretty much doubled the maximum sample size, still 90 per arm. I haven't addressed the problem, but I'm now simulating I've got a 12-week endpoint. So FACS is going to report actual sample sizes, including the overrun. I've added 5 more treatment arms. And while the first 5 arms have got a start date 0, so they start at the outset of the trial, I've assumed the following 6 arms arrive at sort of half-yearly intervals. And what we specify is an arrival window. The first earliest it might arrive and the latest. So basically, I've given each one a 26-week interval in which it might arrive from within the first 26 weeks of the trial starting. And then I've said each treatment will, from arriving, will be available for a year. If the trial doesn't permit it to enter, then that treatment's going to go away and we won't be able to use it. Someone would have gone off and tested it separately, perhaps. I've also added a new response. I've replaced my alternate with one where I'm sampling from a distribution. So I've got my distribution. So this is going to allow me to, if we actually kind of managed to come to a kind of a consensus, although we could have several consensuses in several scenarios, about what the likelihood it is that a treatment will be successful. I've said, well, I think there's actually 2/3 probability, 2/3 of the treatments will be duds, and only 1/3 of the treatments will have any kind of treatment effect. And then if it has a treatment effect, I'm going to assume if the treatment effect falls in a range around about 0.8 with a standard deviation of 2. So roughly speaking, I'm expecting to simply see true effect sizes of between about 0.4 and about 0.12. No. Again, I've been not simulating any dropouts. I've left the accruals the same. My quantities of interest are the same. The modeling is the same. I've left the allocation the same. I've left the updates the same, but of course, what will happen now is they will just keep on running. These might not be the right intervals to do those. I've only just realized that the right intervals to do the updates at now. Because once we've got fewer, if we have a point where there's fewer treatment's going to reach its 30 or 60. So I could simulate just doing the update when treatment reaches a milestone. That's probably what I want to do. Then these criteria have been left the same, except I've adjusted the final p-value now to 0.025. I'm saying, hey, this is a platform trial. I'm testing different treatments. It doesn't make any sense to require me to have an overall family-wise error rate, because what I'm doing here is replacing 10 different trials, which as regulators, you would have been happy to accept each one individually as having a time on error rate of 0.025. So let's allow that for each treatment within this trial. I think that's becoming accepted by regulators. It's certainly in the FDA. Europe's still a little cautious about signing up to this. They still have some caveats. So I'm just going to resimulate those. I'm just doing 1,000 simulations for the sake of time. I'm also not doing them locally on my laptop. I'm using our little compute grid, trying to get them done more quickly. So we can see that they're a whole bunch running. How much time have I got? Let's hope some come back before this call, before the webinar finishes. So we've got our first packets of 100 results left after the first 2 packets have come back. Hopefully the rest should come in a bit of a rush. So we've got all the results back for the least favorable configuration scenario. So you can see we haven't managed to actually analyze all in every simulation, 10 treatments is the average number of treatments is a little bit less. You can have a little look at that. We can look at the per simulation chart showing what's going on. So you can see here we've got we're looking here at time on the y-axis, and then of course each treatment. Sorry, I think my axis is a little bit today. Time on the x-axis and the treatments up here on the y-axis. The bar shows the period for which a treatment is enrolling. The dashes prior to enrolling show the period the treatments are available, and then the little dashes at the end show the period in which the last recruited subjects followed up. The solid X's and diamonds show the actual outcome. So pink X is early futility, red X is late futility, solid green diamond is late success, and the pale green diamond is early success. And then on the other side of it, we've got a hollow X's and diamonds, and they show the truth. So this diamond was a treatment, was indeed being simulated as a good treatment. It should be successful. This one here is a type 1 error. It shouldn't have been successful. It might have been a full type 1 error. It might have been a null, or maybe it's oh no, yeah, from this is the LFC. So yeah, this would have been a null. But here you see a treatment not getting into the study. So that's its year of availability, and the trial has had 5 treatments in that whole time. So it was unlucky in coming in slightly early in the window, and certainly 4 of these treatments going right to the end and requiring full enrollment. So that's why we're not always getting all 10 treatments tested. And then we can look at the type 1 error. So in the null, where they're all 10 treatments are null, the mean number of successes of unacceptable treatments is 0.225, but that's of course out of the 10. So the probability for an individual treatment would be null treatment would be 0.0225. And then in the least favorable configuration, the mean number of good treatment successes when there's only the one good treatment is 0.966. So that has gone up because we've changed the final level alpha test. So a quick whistle-stop tour of the MAMS trials and platform trials in 3 different tools. I hope that was interesting. Thank you very much for attending. As we've done with all the previous webinars, the links will be sent out tomorrow to the recording. Feel free to download it or share it with friends, colleagues. And now this is the end of the webinar series. We'll be updating the website with links to the recordings and slides. If you've got any questions, please feel free to contact us. Myself, Tom at Berry Consultants, and Kurt Veely, and in general, the whole FACS development team at FACS at Berry Consultants. And if you'd like to arrange a demo of the software or a free evaluation copy, then you just have to ask. Oh, I see there's one more question.
Yeah, I accidentally clicked live and then couldn't answer in text. So you can answer it though. Are the true effects in each arm being randomly sampled in each simulation? So the specific 2/3 of the arms which are ineffective are changing from simulation to simulation.
Yes. So in the scenario I created, where is it? Here we go. Where in these 2, the first one, the null and the least favorable, there's no sampling. The response is fixed, and the patient responses are sampled from this fixed distribution every time. In this one, what I've done is I've specified that the treatment response is to be for each of the treatments, but I can choose separately, is to be sampled from this distribution I've created, distribution 1, which is set up on the treatment distribution tab, and that's the distribution I showed and described during the talk. So in this case, yes, in every scenario, in every treatment, for every treatment, the response to be simulated for that treatment in that, sorry, not in every scenario, in every simulation for every treatment, the response to be simulated in that simulation for that treatment is sampled at the beginning of the simulation from that distribution. So they're not sampled once, and that becomes a scenario, which I think was the question. They get sampled every time. But no, that's a good question. Need to make sure that's clear. Okay, well, yes, I hope you've enjoyed the series. I hope you've got something out of it. And yes, don't hesitate to get in touch with us if you have any questions. Thank you very much.